the history of medicine is full of so many products that actually we thought it's going to work in the test of clinical trials. So, so now we have clinical trials in the FFR, and now we have clinical trials in the IFR, and with the hard point clinical. The question I have to both the debater: what do you think about the diastolic, like the diastolic indices when you just PA over distal in the diastole? It's not even IFR, and several of the other people now are proposing this as equivalent, and they bring as an evidence that it actually correlates. Would you believe that, or would you still require clinical trial?
So can I synopsize that question?
Yes.
Do we need clinical trials for every non-hyperemic diastolic pressure ratio that is being developed? Would that make it short?
That's short.
Okay. So let's just get short answers on a short question. Arnold?
Yeah, so we have increasing data from over 3,000 patients now, most recently by On at TCT last year, which showed that the areas under the curve are like 0.996 for all the newer diastolic pressure ratios. We know that they are numerically identical with, at a range that is less than the retest variability. So essentially they're numerically identical, and therefore probably not do you need a clinical trial. And the FDA has already approved these DFRs, and the RFR on that basis. The FDA doesn't think that we need to do a clinical trial, and so it's probably a moot point at this point. We don't need a clinical trial because it's already available. Both of them are already marketed.
Dr. Hakim, do we need a clinical trial on the IFR in every clinical scenario that we have data from the FFR population?
No, I agree with Dr. Cito. I think just because there is a 99% correlation, doing another randomized study for each of them at 2,000-3,000 patients to show a difference is a waste of time and money. I think since they have great diagnostic agreement, if I personally use FFR, which is why I was given this part of the debate, but I think it has a solid role with a few limitations. I think PDPA is universally available. There are multiple other indices. I don't think we need randomized trials to ascertain the role of each and every one of them.
Okay, so let me ask a question of the two presenters. Since IFR and the non-hyperemic pressure ratios correlate 80%, in whom do you use FFR in the remaining 20%? Or under what circumstances would you absolutely use FFR and not a resting ratio? So Dr. Hakim?
See, for me, again, I have an obvious bias. To me, when a patient comes to a cath lab, he's undergone a slew of diagnostic studies and whatnot. And oftentimes, patients drive 3-4 hours to come see us. And to me, it's our opportunity to do one test and do a test that we are absolutely confident of. Now, obviously, someone has severe asthma or severe COPD, and I'm concerned about giving them adenosine, I would not. For all patients, I still use adenosine in the majority of physiological evaluations that I do.
Okay, so you use FFR all the time if they have to drive a long way?
No, not necessarily. Even if I need it on a friend, on my neighbor, I want a test that has a legacy that's proven. Yes, I understand there may be cost issues, but if you look at the overall clinical decision making and the outcomes, to me that is a more robust test, is a more solid gold standard.
So same question to Dr. Cito. When do you not use IFR?
So every time we've tried to look for a subgroup where IFR might be inferior to FFR, we haven't found it yet. The proximal LADs turned out to be about the same outcomes with defined flare. And same thing with ACS. It might actually, there's some suggestion that the IFR may actually be less prone to error than the FFR. I say clinically, I agree with Dr. Hakim. The patients coming in and they want the best tests. And right now I don't know which best test there is. And so I do both. I do an IFR and an FFR in every patient because an intracoronary adenosine FFR is quite quick and without symptoms. And so I typically will do both and therefore get a sense for what their maximal hyperemic phase would be, and I tend to pick the one that I like because whichever lead.
That is such a weak answer. Arnold, come on, help us out here. When do you not use IFR? So we'll come back. We'll come back. Yes?
So, what about left main disease, post-PCI, side branch disease, and diffuse disease? Would you ever choose non-hyperemic modalities in these situations?
So panel speakers, when would you, so left main, side branch, diffuse disease, post-PCI, is IFR or non-hyperemic ratios validated for use in these conditions?
Okay, so for left main, I personally, especially if there's downstream disease, I don't like using FFR. Interpretation is problematic. I use IVUS if there's a question. For diffuse disease, I think they're about equivalent as long as you've put the wire in the very distal coronary bed. Post-PCI, we use FFR because that's where most of the data is. And I'll be honest, in side branches, I've had a few instances where we jailed a side branch, the wire broke off. So I do not like putting pressure wires in the side branch. I may do it up front to see, but then, if there's plaque shift, that changes. That doesn't really help us a whole lot. One more point I'd like to bring up. Now, say you have a patient who has a really good clinical story, has a 60% CIRC or RCA lesion, very classic angina, but angiographically it doesn't do justice to just go ahead and put a stent there. You do an IFR, and the IFR is 0.93. The question is for Dr. Cito. Are you going to give adenosine, or will you stop?
I will concede both points, that I would give adenosine and check the FFR, and I will also concede the left main because there's no data for the IFR in left main, and there's more rigorous data in the FFR.
See, he just agreed. That's the gold standard. Adenosine FFR is the gold standard. Yeah. So, all right.
We have one more question here. George?
No, I just want to make a comment that finally, through many questions and answers, we'll get into some practical points. Both of these tests are using wires. In the last comment, for the first time, I heard that the quality of the wire makes some difference. And we don't want to put wires that are not optimal through stents in side branches and all that. I wouldn't agree more. There are certain lesions that, by looking at the tortuosity, you don't want to engage with a wire that is not high quality. And in those cases, maybe an FFR may be more possible. On the other hand, it's extremely practical. You have a wire down, you haven't started any medication. Why don't you just do an IFR? It's right in front of you. You want to have the FFR as well? You just push a button, you give the adenosine, have the FFR as well. That's the answer to the last question that got the IFR, but there was some disparity with a clinical scenario, and strongly suspecting maybe you need to supplement with something. Well, it's not so difficult. You just push another button and give a little adenosine in a few minutes, and you get your answer. I'm not sure it's so complicated as we try to make it.
Did the FFR and IFR complicate issues now? Because you actually added a measurement. And I want to know what you think of a strategy of doing IFR, and there is a gray zone in the IFR. Then if it's in the gray zone and you're still not clinically convinced, you do the FFR. Is that a valid strategy?
Yeah, it's always been a valid strategy ever since the hybrid algorithm with the IFR, and it may be that range of hybrid where you are not concerned, where you're concerned, there might still be a change. Maybe that's narrower now after defined flare, but strictly speaking, if you had a cutoff of 0.89, that's how the outcomes turned out. But if you had an IFR of 0.90, 0.91, and you're still very worried, then there's nothing wrong with rechecking the FFR as well. And we don't have evidence that the discordant lesions are of concern, but we don't have evidence that they are not either. It's inadequate numbers for clinical events, and that's the challenge.
Okay, one last chance for the audience to throw up a question. I don't see any. I just want to comment, not all pressure wires are the same. So please pay attention to the changing technology when it comes to addressing side branches and so on. Every wire produces PDPA, rest. Proprietary algorithms for different diastolic period measurements come from different companies. So part of your consideration to what wire you're going to use depends on the quality of the wire and the information you want to get.
So in conclusion, what I had one more slide to show was that in the end of the day, with the IVUS, you try to do something. You don't just do the technique in order to use the technique. And you try to have a pre-intervention assessment, a stent deployment, and to avoid complications. Identify edge dissections, determine a position, and identify tissue protrusion. With experience, you can learn to do that in most of the cases, so it's really all about the operator experience in the end of the day, and you can fill in here and there. It's a good idea for the complex cases, maybe the long, the left mains, etc., and use the intravascular imaging for those. Thank you for your attention.
Thank you. So we're going to have some discussion and questions, but could I ask the back of the room to close those doors? I can hear those people talking in my ear here. So this is a great discussion on IVUS. We know that only 9% of the interventions in the U.S. are performed with IVUS, and we're not going to address why the use is so low, but George, you don't think we need IVUS in every case. And we know that left main was a class 2 indication. I was under the belief that left main was an every case use of IVUS, left main stenting. Am I right? And I'll also hear from our colleague Franzapar on that.
So in terms of class 1, I totally agree with you. I mean, as you know better than me, you have to have randomized clinical trials, sometimes more than one, to really get to the class level. And it goes through, that's the same thing for many things, intervention cardiology, what incremental value we have with these additional tools or new stents or whatnot can be not easily shown in actually, and we cannot do that many randomized clinical trials. That's why I think we don't have class 1. But at the end of the day, I think, as you mentioned, in many cases, subgroup long stents, complex lesions, calcified lesions, instant restenosis, and bifurcations, all that in intravascular imaging is going to help you. And I think in our daily practice nowadays, this is actually more than 80% of what we do. So I don't know how many type A lesions.
I got to interrupt you.
Sure.
Because the issue is left main stenting. And I'm sure that many of us feel that this was an admonition for not using IVUS. You need to use IVUS to make sure your left main stent is well opposed. Is that now no longer true?
I don't know. I mean, personally, I always use actually intravascular imaging.
George,
there's no
is
way
that
I
true?
leave the patient without intravascular imaging.
Well, not always true, because there's always a situation using IVUS, and then you decide where you go, let's say, with a 4.5 balloon. Is that fair? Well, how about if I use a 4.5 balloon at high pressure anyhow? And then I'm very pleased about the pot technique and all that, and I don't have any reservation. Maybe it's not a double stent left main. What's IVUS going to get me? To 5.5 balloon? Would I ever use a 5.5 and risk a perforation? If the answer is no, maybe what exactly am I going to do with the IVUS in some of these cases?
So George, there are IVUS, actually the operator changed the decision when they used IVUS, but more than 60 to 70% of the times. And in addition to that, we know from the angiographic studies that the bigger the vessel, actually the less ability of the interventional cardiologist to be able to judge the stenosis. And we know that from the peripheral and especially the left main coronary artery. We are really poor judge of significance of the stenosis. And I think using the IVUS, as I actually concur with more, like I thought this is must in every case. Because first of all, and we'll use the IVUS to plan the procedure and then to execute the procedure, not only to kind of look after we put a stent. I'm not sure what the panel discussion about, opinion about that.
Yeah,
Let's ask.
I would take it even a step further. I was image post left main, and not all left mains are 5, and I actually would argue they should IVUS the proximal vessels as well. If you put a stent in the prox LAD, going back to the OS and potentially even prox circ and RCA.
So, George, when is there an absolute use of IVUS? I mean, maybe we should. Maybe I understand now why only 9% of cases are done with IVUS.
Yeah, well, the absolute use of IVUS, if you have a question that you're not answering yet. If you have a question, is there a dissection? Could there be a dissection? Because I don't have an optimal view. Could I possibly use a bigger balloon? If the answer to that question is no, then what's the point if you can't use a bigger balloon? If the vessel looks 4.0, you've already used a 4.0, 4.5 balloon, then you're not going to go to 6.0, so to 5.5. What's the point? However, if you use a 3.5 stent and you didn't post-dilate it because you want to do a quick and dirty job, well, maybe you're, maybe you have to use IVUS all the time in order to kind of, train on exactly how to, bring up your skills up into judging those things a little bit better. In the end of the day, it's hard to say that every single case is to be used. However, there are many cases that you are in doubt. Should I use another balloon? Maybe I should not. Maybe I should. In those cases, I think perfect for IVUS.
I think the challenge is sometimes...
Let me ask the panel. So I did think I made a mistake once when I was using IVUS, but I was wrong. So Arnold, what is your take on IVUS frequency use?
Right, exactly. I wanted to pose the question. And, the problem probably with us as interventional cardiologists is that we have overconfidence in our abilities and we don't ask the questions that we should. And so I would ask the panel, given the data, what is the right percentage? How much should we be using IVUS across all comers? And now that we're at 13% in the US, should we be 90% like Japan, or should we be somewhere in between? I'm guessing 30% would be good, and it certainly would be progress.
So let's just take each individual and give us a short answer, and the percentage of use of IVUS to be expected in a good practice. Japan 90%, US 10%. What's the right number? What's the right number for IVUS use on the end there?
I would say probably at least 75%.
75%. Next?
I would say 50%.
50. Arnold?
I already said 30.
30.
I agree, 35%.
I say $1. No.
$1.
No.
Okay, right here.
40.
Good
I say
man.
less than 50, but 40-ish to 50.
So it depends on your practice. So if you really have a very complex practice, you're probably 90%. If you practice between lesion A, B, and less type C lesions, probably 50, 70%.
So I'd say 100% if you're reimbursed and 10% if you're not. Okay, George?
Yeah, I think 25 to 30% would be a good incremental step from where we are now in the under 10%. So hopefully we'll reach those soon.
Okay, good. I'm sorry we don't have some of my colleagues from St. Louis in practice up here to give me the right answer, but we're going to do that.
Does
Does my hospital need one of these programs?
Does yours?
Yes.
Yeah, sure. Why not? No, honestly, we try to move. So we're working with the Columbus Fire Department, which is about the city proper is just under 1 million, and you can only take so many patients. So we would like to expand to cover the whole city of Columbus and do a citywide with all the other major hospitals, private and academic, to serve the whole community. And we've tried. The problem is it's expensive. There's high mortality. Your outcomes get reported publicly, and your cath PCI numbers don't look as good.
Those are not positive features.
No, they're not positive. But the thing that is, these are 100% mortality. If you pick the right patients, the data across all these studies, you have 20 to 40% survival. And I could tell you, when you see one of those saves, we feel like it's worth it. Now, obviously, you're going to have a lot of bumps, and you're going to see a lot of bad cases. But essentially, I think if this can be a widespread throughout the city, including your hospital, the hospital next to you, it can be very powerful.
Let me ask Kate, is that correct?
Yeah, I think that's a really good point. One of our issues was that the medic system is then shunting the kind of sickest of the sick hospital arrest patients to our center once this program's initiated. And then meanwhile, kind of the, perhaps recurrent arrest patients who are a little bit less ill are getting shunted to different centers. And so that that allocation of resources and just dealing with the patients is a burden. So I think ideally you'd probably have two major centers in a bigger city, and some dispersion of that would probably help. But that being said, with all the volume issues that we see, there are some changes in outcomes related to volume in shock patients, and there's no reason to think this would be different. So I think it should be consolidated, but certainly something.
I see Dr. Berlakis dying to tell us something.
Well, first of all, I want to thank both of them, especially Kate, for taking this on a couple of days ago. Great job for such a short period of time. But the question is, my question is, are you allowed to die this day and age in the United States, or you have to die through a long process?
Yeah.
It has to be a long process.
Yeah, it's a great question. According to our protocol, if you're 75 or older, you can die. If you're younger, then you survive. No, that's an excellent question. I mean, when is enough is enough. And, you know, and I think that's why you got to be selective and you got to be smart about the people you include in this because, you know, the PA and the asystole, I mean, we have excluded those because the small studies that are out there consistently show these patients do not do well. And if they survive, they have almost no neurological, meaningful life. So you're right, there is a fine line and that's why we also have cutoffs for certain lactates. You know, if your lactate's too high, the data shows your outcomes are poor, so we exclude those patients. We use hard cutoff numbers. If you come in, your lactate's 15.1, you don't get put on ECMO, you know, and so, you know, that's our institutions. Others do it different. I know Dimitri Yiannopoulos up in Minnesota may look at multiple factors and kind of, you know, may not just be as maybe as stringent as we are, but you just need to really look at the data and review your data and see what makes sense.
So question for both speakers. What's your thoughts on the earlier institution? And like I know there is a trial in France to actually put the ECMO in the rig. And the University of Michigan now, the ER doctors actually place the ECMO. Will that make a difference? And the other question I have for Konstantinos, that each ECMO has about 3.4 vascular complication per device. So how do you deal with that?
Yeah, I think we saw the rate of vascular complications was quite high, and like on all other patients, really does relate to mortality, as does all the transfusions that they got. But looking across at all of that, it does make the most sense if we transition to more of a trauma system level of care for these patients, and you could have some kind of program memory of activating for the patients who are witness to arrest with an initial shockable rhythm and getting them on support and then brought immediately to a shock specialty center seems to make the most sense. But just geographically, I know that for us, that would be difficult to apply outside our immediate area as well. So I'm sure those other challenges. But.
Yeah, you know, there's some centers that ER are doing this. Utah's one, Michigan's one, and you know, for us, I don't think it makes a difference. And you know, we are talking about combining all our data to look at the outcomes. You know, for us, we bypass the ER and come straight to the cath lab. You could do this in the ER. You know, we don't know what the difference is. These are limited patients, and so that there are centers doing that. I think I know what you're referring to. You see, I don't know if you guys seen that news article on the subway of Paris where they have the blue,
yes.
You know, the sterile fields and they're putting ECMO. You know, that may be, who knows, one day if it gets to that here in the States. But the thing is, this is very labor intensive and it is costly. And, you know, with the question going back, Dr. Kern, about should your center have it, the thing is, you know, the reason we only work with Columbus Fire, not with the townships and all the suburbs, is it would overwhelm our system. We just couldn't handle it. And that's why partnerships, we went to the other medical centers, the private and academics, to see if we could get a partnership to do a whole citywide, because you take on a lot. It is very labor intensive and it's a lot of strain on the system. Vascular complications is huge. You know, we do distal perfusion to at least help with the ischemia, but even with the cannulas, imagine someone with CPR trying to get access. You know, ultrasound has helped us with decreased our complications, but you know, we haven't had anyone yet die from a vascular complication yet. Most of the patients that don't make it are because of anoxic brain injury.
So let me ask a technical question. You're using ECMO. Could you not get the same result with an Impella? And also, you're not venting the LV, so you are not producing optimal myocardial recovery.
Yeah.
So what's your thought on changing your methodology?
Yeah, well, the problem with Impella is if you do an Impella, you have to put some kind of right support, because if they're in cardiac arrest, it's not
You
going to
need
do.
bi-Impella.
Yeah, it's not going to do anything. And trust me, we've done that in patients when we didn't get ECMO fast enough because we had Impella there, and it didn't turn out well, at least from the low numbers that we have. We do vent some patients. It kind of depends on who's on call, and that's a debate too. I will tell you though, the patients that make it, it's usually not the ones that were vented or not. They made it. The rate limiting step almost the majority of the time, again, is the anoxic brain injury. And that's where you are pronouncing patients. It's not because you vented them or not, or because they had a cold leg.
Right.
Yeah.
Go ahead.
You see, there are a couple of other issues that have to be kept in mind. I think it just comes down to patient selection, and then I think our chemistry as interventional cardiologists, we don't know when to stop. The important thing is, yes, you can put an ECMO in, but if the patient's had ECPR for 40 minutes, they arrive, you put the cannula in. Sometimes the cannula, there's no flow. And we've had a few instances, we've reviewed them. Sometimes it's tamponade, sometimes there's hemothorax. There's not enough blood to be circulated. And the point about venting, the case that you showed, the mean aortic pressure with ECMO is going to be 90. And if the LV is really poor, you're not really opening up the aortic valve. So that makes sense. We try to put, we do a bedside ECMO, and if we demonstrate that the aortic valve is opening, then we do not put a venting device, Impella. But if it's just totally shut down, sometimes you see AI because it's persistently shut down, then we have a low threshold of dropping an Impella.
Good. Do you have to have a short witnessed interval between arrest and treatment?
Yeah, so when we first started our protocol, it'd be interesting to hear what you guys did. We were very well, it's conservative. You're doing ECPR, I guess it's not conservative, but we actually we put in bystander CPR and witnessed, and then we removed it, and that was based on some other sites in the U.S. They removed it because we've had a handful of cases where patients would come in with VT, and people were like, I don't think I felt a pulse, but probably did have a pulse, and probably were perfusing. And so we gave the patient the benefit of the doubt that if they were in VT, they were probably, it wasn't PEA, it's not asystole. There potentially may be some perfusion at that time, so we completely got rid of that. And plus, you got to remember, there's 1,000 EMS personnel. You got to make the protocol simple, straightforward, and it's got to disseminate to everybody. And so we just said refractory VT, VFib, age 18 to 75, the best you can guess, and just bring them in.
Yeah, we similarly kind of took that out because there were issues where people maybe got bystander CPR that was really not good probably at the end of the day once we got more information. So much of that was messy that it was hard to tell. And also some of the response times for medics were like 3 minutes from the time of the suspected arrest. So, and ideally it was witness patients with VTVF, but we weren't that particular.
George?
I mean, the difficulty we have here is we can't really select those viable patients mentally early on. And obviously, that's not a cardiology question, all right? And somehow, we're alone among all other specialties who don't really do as much in this scenario. And that's really where we are. You want to do everything for those who are viable neurologically. That's not exactly within my training. And I just feel that, I never get enough buy-in or help by anyone else, ER, anyone, subspecialists, this and that. So that's why I think this field is a little bit in a standstill. We need others to help us as well.
I have a quick question for Konstantin, since you're the cath lab director at Ohio State. So in terms of administration and insurance and all that, how do you deal with that? I mean, you're doing a fabulous job, saving these patients, but then for the one that you lose, you're going to have a PCI mortality. For many of them, you're going to have bleeding issues. So all of them is going to affect your hospital, and the administration is not like they're evil. They just don't get paid by the insurances. And so how do you convince them? How do you deal with that? And do you think us as society should come up with, more policies, how to exclude these patients from all those quality measures?
Yeah, and it's a great question. So, your public or your reporting for cath PCI doesn't start till you put a coronary wire down and you do an intervention. And the thought was when this first started was that we were going to expect bad numbers. We thought most of these cases were due to ACS that resulted in VFib and VT, but when you look at our numbers, a third of them are actually getting PCI. I presented a case earlier today. There was acute myocarditis. We have unfortunately, living in the state of Ohio, we have a lot of heroin overdose patients that come in. And so if you don't do a PCI, those numbers don't get reported cath PCI. But I will tell you, looking at the last year and a half at our numbers, we've had increase in transfusions, increase in acute renal failure, which will happen to everybody, and bleeding, because it's part of the deal for those 1/3 of patients.
Welcome to my life. we use a lot of mechanical circulatory support, so I'm the cath lab director and also in charge of quality. And every month, I have to look at the bleeding complications, at the CIN complications, and vascular access complications, and all those patients, actually those who received mechanical circulatory support. And so you have to, I'm not sure the risk adjustment model we developed 15 years ago on a data that's 25 years old, it kind of applies to the complexity of the patient we do now. From the ECPR, obviously, the sooner you start the support, the better, and patient selection is obviously a key here. There are patients who, as according to Kate, are futile, and you probably should not enroll them. But there are patients who really miraculously come back and they show excellent results, and the family and the patient live to tell a story.
So let me just take the prerogative of the last 4 minutes of this program and ask the question, should we be supporting our myocardial infarction patients with shock or pre-shock with LV support devices, mechanical, of any kind, before we go to the cath lab and open up the vessel? Reperfusion, support before reperfusion. I'll just take a quick pull down the panel. We'll start on this side. So, support before reperfusion, LV support. Yes or no?
In the patient's clearly in shock, it makes sense to me.
Yes?
That's been our protocol. Mhm.
George? Shock, support before reperfusion.
Yeah, but it's done in the cath lab. How you want to do it outside the cath lab, you mean?
Do it anywhere you want. Support first?
Well, if there's no cath lab immediately, you have to support first instead of doing nothing.
So I'm going to interpret that as support before reperfusion. What do you think?
So I just gave the talk a previous session about that. There is a trial coming. Hopefully we'll know the answer to that. If the shock is there, we support before reperfusion. If the patient pre-shock, you can actually reperfuse and just be ready to support after.
So no, unless they're in shock.
I'm going to say reperfusion for now. We'll see when more data comes out.
Even in shock? Wow. Next?
Yes for shock.
Yes. Arnold?
No support.
No support. Gosh, you guys are tough.
Support.
Support.
So if it's a clear shock, I would go with support, but at the same time get access for my revascularization also. I wouldn't, wait.
Okay.
I think simultaneously.
So maybe just a quick audience poll. Show of hands, you think support before reperfusion has clinical merit, and you would do it if the data, obviously if the data supports it, you're going to do it, but support before reperfusion. In favor of? Shock.
Shock or pre-shock if you want, impending shock or shock.
Okay.
Okay, and those, no support now.
No support, just go right to the cath lab in shock, open the vessel.
Or they listen to
I
you.
don't think they're telling the truth.
They listen to you. They want you to do it though, not themselves
Okay.
maybe.
So
All right.
I'm gonna leave everybody with that provocative thought. I'm gonna say thank you to the panel and the speakers. Thank you all, and manos in abstentia.